Hello, everyone. Thank you so much for joining us today. My name is Shane Bryan, and I am pleased to be here with a wonderful panel of folks from all over the country, quite frankly, who will be able to share with you more about their experiences through the public sector consultations offered through the Bloomberg American Health Initiative. Before we get started, just a really quick introduction to the initiative and to the folks that you're seeing on your screen and you'll hear more today. The Bloomberg American Health Initiative is a project within the Johns Hopkins Bloomberg School of Public Health and started in 2016 thanks to a generous gift from Bloomberg Philanthropies at the centennial celebration of the school. The Bloomberg American Health Initiative focuses on 5 key areas: addiction and overdose, adolescent health, environment, obesity in the food system, and violence. All of our work at the initiative falls within these 5 areas. We also have 3 cross-cutting themes. They are equity, evidence, and policy. Today, we're going to talk to you more about the public sector consultations. And you'll hear more from folks who have participated, including Dr. Amanda Lattimore, who has been leading this work at the initiative. A really quick update for you all who are attending the live session. If you have any questions, please feel free to either use the Zoom webinar chat function or the Q&A function, and we'll be addressing questions later on in the webinar. To get us started, I'm going to hand it over to Dr. Amanda Lattimore, who will provide you more information on public sector consultations, an overview, and introduce you to the panelists that we have joining us today. Amanda?
Hi, everyone. Thanks for joining us. Also, thank you to the panelists for joining us on this webinar. So I'm faculty in the Department of Epidemiology. I am also the Public Sector Initiatives Lead for the Bloomberg American Health Initiative, which is one of my roles is to build bridges between academia and governmental agencies through a fund that incentivizes faculty to participate in consultations. So I will talk a little bit more about that later. I've also worked in the public sector myself, served as the Director of Epidemiology and Evaluation for the Baltimore City Health Department and also with the Behavioral Health Authority for the city. So I have a little bit of experience in both worlds and tried to bring that back to the school and help facilitate some of these relationships. I will now, if I could have the panelists introduce themselves, if you could give your role in the organization that you represent, and I will start with Anne.
Thanks, Amanda. My name is Ann Palmer. I'm an associate scientist in the Health, Behavior, and Society Department and also work at the Center for Livable Future. And I worked with Dariel on providing assistance to George Reisted in Madison, Wisconsin.
Thank you, Anne. George, did you want to introduce yourself?
Yeah, sure thing. Thanks for that intro. And so my name is George Reisted. I'm the Food Policy Director in Mayor Satya Rhodes Conway's office in Madison, Wisconsin. I won't steal my own thunder, I guess, so maybe I'll leave it there. I'll tell you exactly what we did in a couple of minutes, I guess. Thanks.
Great. Dariel.
Hi, excuse me, this is Dariel Harris. I am a 6-year doctoral candidate in the Department of HBS. I work at Center for Livable Future under Ann Palmer.
Great. Daryl Gaskin?
Good afternoon. My name is Daryl Gaskin. I'm the Richardson Professor in Health Policy in the Department of Health Policy and Management in the Bloomberg School. And then I'm also the Director of the Center for Health Disparities Solution.
Great. Katie?
Hi, my name is Katie St. Amand. I work at the Rhode Island Department of Health on the Health Equity Zone Initiative, and I am the kind of epidemiology and evaluation lead for that initiative.
Great. And then our final project, Sean.
Hi, everyone. I'm Sean Allen. I'm faculty in the Department of Health, Behavior, and Society. Most of my research focuses on opioid use and the opioid crisis. And I have been working with Dr. Michael Kilkenny working with him for a few different years and had a few different projects.
And last but not least, Michael Kilkenny.
I'm Michael Kilkenny, and I am the Physician Director of the Cabell-Huntington Health Department in Huntington, West Virginia. We have a substantial opioid and injection drug use problem. We have had a sizable HIV outbreak, and we've received invaluable assistance from the Bloomberg School of Public Health through Dr. Allen.
Great. Thank you so much. I'm going to share my screen. All right, so we have gone through the introductions. So I'll just give you a brief overview of the consultation program. And then following that, we'll showcase each of these collaborations. We'll have a discussion with the panelists. And then hopefully, I'm excited that we've got so many governmental agencies registered for this and some faculty as well. So I'm hoping that there are questions. As Shane already mentioned, please put them in the chat box. And we'd love to, whatever questions you have, we'd love to share those with the panelists. So please participate. All right, so there's a growing recognition that often in research, there are a lot of faculty who participate. I'll just start with that. A lot of faculty participate with sharing their knowledge, translating their research findings, but there's also a growing recognition that more of that information needs to get back to those who are making the decisions every day in the field of public health. Also, there's a lot of knowledge and expertise in our governmental agencies, our community-based organizations that could really get back to researchers and inform what kinds of questions they ask of their research and how that information can best be presented to them. So there are a number of barriers that research has identified, research here at the school has identified. It includes individual characteristics, things like not having the introductions or the networks. There are challenges in translating certain kinds of research, having the culture within an organization and the knowledge to translate your research, and proximity to policymakers. So we're lucky to be close to DC. And then there are also some other factors like departmental reimbursement for cost accrued, as well as incentives for faculty to participate, promotions, and an inability to carve out time. So given those challenges, one of the priorities for the initiative, of course, is to build these bridges. So they provided incentives, financial incentives for faculty to participate in public sector consultations. And what this allows faculty to do is to provide a scope of work, a project that is up to 100 hours, and faculty are given a financial incentive for those hours and work together with governmental agencies to identify projects and implement those projects. And we support them throughout that engagement. And that's led to a number of funded projects through this public sector consultation program that include things like building capacity for geospatial analyses. Sean Allen actually is involved in that, developing hospital-specific report cards for maternal outcomes that occurred in New Jersey, design and piloting a policy to increase access to healthy foods here in Maryland, assessing the feasibility of fentanyl test strips, that was in Delaware, developing performance metrics and identifying priorities for food policy initiatives that actually Anne could if she has time, talk about that as well. use data to prioritize transportation interventions. That was through the Navajo Nation. And then finally providing input on opioid-related priorities and metrics, and that occurred in Maryland. So you can see that, you know, this is not just specific to our location here in Maryland. We have been able to facilitate projects across the U.S. So I'd like to take this time in the next, 10-15 minutes for each of the groups to share a little bit about their project, what motivated their collaboration, the experience of going through this consultation process, the results of the assistance, the technical assistance, how that experience impacted their work, and then finally any lessons learned through the engagement. So I'll start with the food policy project, and I will stop sharing my screen. All right, Anne. Or sorry,
Ariel.
Ariel, yes.
Yes, sorry. I'm having a rough time today. So, so what happened with this? What this project entailed was the city of Madison indicated that they wanted to have more inclusivity in the impact of their food policy council, and so I spoke with George, who's on the Zoom call, several times, and Anne was involved as well. And then eventually I scheduled a trip to go to Madison to kind of see the lay of the land, to see some of the projects that they had implemented already, and to attend a food policy council meeting. So I did that. I went to Wisconsin. George showed me around, and I met with people from different levels of the Food Policy Council, people who have been impacted by the council, people who are store ownerships and shop ownerships, shop owners who were working with the council on one project or another. And then I met with various members of the Food Policy Council leadership, and I attended a Food Policy Council meeting. The goal for all that was to come up with some sort of paper that would identify strategies that Madison could utilize to have more community engagement, specifically more people of color. And so I did that. I have a background in organizational management, and so I went there and I saw that they were doing. I saw who was impacted and how it was impacting people. I read lots of a few city documents around the city government structure, and then I was able to produce a document that had a fair amount of implementation strategies that could be utilized to include the number of community members who are involved in their projects and who are impacted by their projects, specifically looking at people of color. And then, Anne, do you want to talk about the governance docs?
Sure. So I also did an assessment, and it was looking at, so food policy councils are groups that come together with the goal of trying to represent as many sectors as possible of the food system. And they are kind of bringing to bear what they know to a larger group to try and assess what's happening in their jurisdiction and what sort of actions can they take specifically around policy issues. So it's less programmatic in focus, but a lot of groups also focus on programs. And so what I did was put out a call to groups. We manage a large national project of food policy councils to find out how they were doing exactly what George is interested in doing. And we gathered, we know a lot of the groups that are out there working, and we gathered a number of examples that lined up with Daryl's report in terms of like, what are the big areas that you can really work on, and created a table of what they were, how they were operationalizing equity and community engagement, and have kept that table kind of going and keep adding examples to that. And I've actually shared that with a number of jurisdictions already that have been interested, because there's a lot of interest in this topic right now.
So maybe this is where I jump in. So I don't necessarily want to completely repeat what folks were saying, but on the Madison side of things, to Ann's last point, I mean, this is an issue that I think a lot of municipalities, a lot of counties, a lot of places are dealing with, and a lot of organizations are trying to deal with, right? Like there is by and large a lot of lack of representation and diverse representation, especially on these highly formalized groups, housed within city structures, right? And so in our case, we call them BCCs, boards, commissions, and committees. Dario mentioned that he had did some municipal research and read some of the publications and documentation that was written here in Madison. There's actually a group called the Task Force on Government Structure, TFOGS, that was kind of wrapping its work up right around when Dario came out in late January. And one of the things that it touched on was that all of the BCCs of the city were having this problem, right? And that it wasn't just the Food Policy Council, it wasn't just, Community Services or the CDBG committee or any other one. It was basically every committee was having some sort of struggle or some sort of, had hanging questions around how they could be more impactful around diverse inclusion, but also around the impacts of their BCCs towards diverse communities. And so I guess, I don't put it out there like to get us off the hook or whatever, but it's just a question that I think everyone is kind of grappling with in one way, shape, or form. And so we had that understanding that we had a disconnect between, diverse constituencies in Madison and the working composition of the Madison Food Policy Council itself. And so we wanted to collaborate and work with CLF to determine, Center for Livable Future, to determine, one, what was our current situation, and then two, what could we do to improve our commitment to racial equity, with particular concern to our city committee, the Food Policy Council, and an eye towards more diverse representation and achieving outcomes that were more impactful to communities of color. And actually, I should mention, because I think, Amanda, you said if, Ann, you might talk about Indianapolis later. I should mention that my conversations with Shelley Shuttles at Indianapolis, she's no longer in the role anymore, but as the Indy Food Coordinator, she was the one who actually really pushed me and said, we've done great work with CLF around metrics and determining what things are most impactful. If you're having, these questions around diverse inclusion, you should really talk with folks and set this up. So that was kind of what started the ball rolling on our end. So thanks to Shelley and obviously to Ann and Dario for that. So I don't want to be too long-winded because I know there's other speakers, but the motivations of this I think I provided, but some of these other questions around what were the next steps, what was the experience like? So we worked very closely with Ann and Dario, who in the end ended up authoring this report with, I think, Ann providing feedback on it as well. It was a very smooth process working with Dario, very good communications and follow-ups. Again, we did set up a site visit, which I thought was kind of what really set it apart, because instead of just talking about these things theoretically and having me essentially serve as a secondary source of information, he was able to come out into the community, come to our January meeting of the Food Policy Council itself. Obviously, this was all pre-COVID. And then go to conduct a couple of site visits and interviews at Luna's Groceries, which is a small Dominican-owned corner grocery store that one of our programs, the Healthy Retail Access Program, provided 25% of their startup funding for, and that sources produce and provides a food access source in a community that had really been without one for about 10 to 15 years. And then he was also able to visit Northside Planning Council's Feed Kitchens, which operates as a shared use commercial kitchen within Madison and is really one of the few of its kind in the area, and has really served as an entrepreneurial boost for food systems enterprise in the city. And through which they are members of the Food Policy Council, or at least some of their staff are members of our Food Policy Council. We've also been able to offer them funding. So to wrap up here, the report was crafted in a way that had very clear recommendations for diverse inclusion and representation on our council, as well as methods to increase the impact of our work and recommendations to ingrain racial equity into the culture of our Food Policy Council, which I think is really important. There was also this addendum that Ann mentioned, which offered up strategies on what other groups and Food Policy Councils have used, which I think will be very useful to our group. So because of COVID-19, our Food Policy Council and then our counterparts at the county, the Dane County Food Council, have completely restructured our work groups, as well as our meeting format and collaboration scope. So now we're meeting in tandem. The council and the city food councils are actually meeting together, which we had not done before. And so because of all of these, structural shifts, foundational shifts, just because the kind of the fabric of our reality has shifted. We're just now, staff and kind of our steering team is just now beginning to think about how to retrofit, if you will, the recommendations provided by this report. And actually that may be a good point for a follow-up consultation in terms of what changes could we make, you know, looking to the list that Anne provided of the other 40 jurisdictions and what they're doing, how can we kind of tweak and craft those things for Madison? So I'll end there. It's been a great process. It's been very helpful. Obviously, because a lot of things that have happened, we haven't been able to take the implementation steps that we wanted to, but we're kind of on the cusp of being able to figure out where to go from here.
Great, that was very interesting, and I have so many questions, but I will let the other groups provide a summary of their projects, and then we will launch into a discussion. So, Daryl, would you like to begin, or would you like your public sector partner to?
Well, I think it probably would be useful if Katie would go ahead and describe what Rhode Island is doing in the area of health equity zones, and then I'll talk about what we provided them.
Mm-hmm. Yeah, so I guess I can start by giving a little bit of background on what the Health Equity Zone Initiative is in Rhode Island. So we started the Health Equity Zone Initiative in 2015, and it is a place-based, community-based initiative that is really intended to give support and to empower communities to come together and determine what their most pressing needs are in terms of social determinants of health and health equity issues, and to develop their own action plans and implementation plans and execute work at the community level. So this kind of all is based on the impetus that, you know, the public health work traditionally can be somewhat top down, and, you know, a lot of times it's federal funders or state funders going into communities and telling them what to do. And so this initiative is intended to kind of flip that dynamic so that the communities are telling us at the Department of Health what they need and what is most important to them. And then we try to, you know, kind of pull funding together and provide, you know, guidance, technical assistance, support to help them implement those things. And so with this consultation project, this was initiated by our former physician lead at the Rhode Island Department of Health in our Health Equity Institute. And at the time that this project kind of got started, there was no dedicated full-time evaluator for the initiative within the Department of Health. So I think we were really looking for external help, basically, to really strengthen our evaluation of the initiative. At that point, we were, you know, 4 or 5 years into it, and evaluation of the initiative was really pieced together with the help of epidemiologists and evaluators across the department. But we really needed some professional help, I guess you could say. And at the same, around the same time, so that was, you know, I think back in like early spring 2019, and then I was hired at the end of May of 2019. So this project just kind of went on for the first, you know, 6 or 7 months of me being in this role, and has been really, really helpful. So the project initially was intended to be, you know, help us develop an evaluation plan for the Health Equity Zone Initiative. And throughout the whole process, working with Daryl and working with Jamar, who was also helping, we just, you know, a lot of our time was spent talking through all of the challenges that come along with evaluating a innovative and like unique community-based approach. So within all of our health equity zones, you know, because the community is determining what their needs are and determining the best way to approach addressing those. Because of that, every community is doing something different. Everyone's doing it in a different way. And so finding, common evaluation measures across all the health equity zones is really, really challenging. And then at the same time, we have, statewide kind of interests and statewide work in health equity in general. And, how is the state working together to address housing or education or, the natural environment and the climate and all these different health equity issues that our communities are facing. So a lot of our conversations were, thinking through all of the different layers of evaluation for the health equity zones. Oh, and I guess I should also mention, like, evaluation structure-wise. So each health equity zone is responsible for their own evaluation. So they come up with their own action plan and evaluation plan and execute that themselves. And then my role and our team's role at the Department of Health is in part to kind of bring together all of the evaluation work that all of the HESs do to tell kind of a complete story of what they're doing. And also to look at some initiative-wide measures around how are they building capacity in the community through, building their partnerships or getting funding from other sources and that kind of stuff. So, ultimately our project ended up being kind of a guidance document to help the HESs think through ways that they could evaluate the types of projects that they work on. So a lot of the HESs do projects related to housing or related to food access. And so we decided to kind of look at those different kind of content areas or issue areas and see what have other initiatives or communities done in those areas before and how do they evaluate them, and what are kind of some like basic things you can do to think through the evaluation of all the different initiatives that you have going on. And I think it was a really, really wonderful and helpful experience. And, evaluation is super challenging, and for our initiative is super challenging. And I think that this is helpful in a direct sense for providing guidance for the HESs themselves, but also it's really helped us think about how we are communicating about evaluation of our initiative within the Department of Health and with our state partners. And yeah, I think I'll pass it off to Daryl.
Yeah, thank you, Katie. That was a great description of both the Rhode Island HES initiative as well as the work that we were doing for you. I think when we first initially got involved, what we thought we would be doing is helping you all sort of do an overall evaluation of your program. And then once we began to review the documents, and this is myself, and I want to acknowledge the work of Dr. Jamar Slocum, who was an internist who was a part of our MPH and MBA programs here, graduated this past May. But we began looking at how, one, diverse the different HESs are in terms of what they're doing, and then two, that they are working in the social determinants of health space, and some of the interventions are designed to impact things that are quite distal from health outcomes. And so it didn't take us long to sort of at least figure out that if we were just going to base the success of these HESs on health outcomes, that some of these health outcomes are things in which you would expect that have 5, 10, 15-year horizons. And so I think if one of the things that we consider an achievement here is that we've helped you all make the case to those stakeholders that they should not be looking to monitor immediate health outcomes as successes for these HESs, because you're not going to see those health metrics move quickly because you've done some efforts in improving housing or improved health education or did some efforts with regard to food nutrition. So then the idea then was, okay, well, since they're working on these distal factors, what is it that they should be measuring? What are ways in which they can sort of demonstrate that they are being successful? And so our whole argument is that if you buy and you're willing to accept that there are social determinants of health and that they do have a positive influence on health if you provide people with things like good housing, good health education, proper food and nutrition, information about vaccine use, improvements in overall education. If you do those things, you're going to improve health. Then what we then just need to focus our evaluation on is whether or not you've moved the needle in those spaces. And so then our report then becomes examples of how do you measure that you're moving the needle in the spaces? And then we selected the ones that seemed to be most prominent among the health equity zones in Rhode Island. So it was a real good experience for us because it really, again, the challenge is that these groups of community-based groups are working in this distal space. And so if you hold them to blood pressure readings, that's just not going to work because they're just further upstream in terms of where these groups are trying to intervene. So I'll stop there.
Hey, that was also very, very interesting. And I can say from my experience, Katie, that the issue of not having enough epidemiologists or capacity for evaluation is not uncommon. So I think this is a great example of how academia can meet the needs of our governmental agencies. So finally, I'd like to turn the mic over to Dr. Kilkenny and Sean Allen for describing a project in West Virginia.
Sean, do you want to start this and I'll take off?
Yeah, I can get us started. So just for background, Cabell County has about a 2.4% prevalence of recent injection drug use, which is pretty high. And the people that are injecting drugs in Cabell County, we did a study there in 2018 and found that most people were injecting crystal methamphetamine, heroin, or fentanyl. And we also found that about 2/3 of people reported getting their sterile injection equipment from a harm reduction program. So knowing that, and Dr. Kilkenny can describe the harm reduction program that we worked with for this consultation fund, they collect voluntary intake forms at each client encounter, and the intake forms ask everything from demographics to service delivery needs. And so those forms were changed in late 2019. So the purpose of this consultation fund was to look at what happened after the forms were changed. So we looked at January 2020 data, and we entered the data. We looked at what people reported needing, what services they were requesting, their demographics, kind of looked at a little bit of everything. And what we found was that there was an incredible volume of people coming to this program. There were just under 1,200 voluntary intake forms that we looked at. And in hindsight, these data, again, January 2020, so a couple months before the coronavirus pandemic, they really serve as a pre-test almost, if you can think of it that way. So with that, I will turn it over to Dr. Kilkenny. He is certainly an expert in addressing everything from coronavirus to the opioid crisis.
Yeah, but my expertise is really in context. I am a local health officer, and in 2015, Huntington determined that it had a problem with overdose and overdose death, and we were leading the state, and the state leads the nation in overdose deaths. So we had to determine what it was that caused us to be in the situation that we were in, whether we were really that bad at using drugs or just exactly what the situation was. But it turns out that just a whole lot of people inject drugs in our community. We started a harm reduction program in 2015 with the guidance that is available to start harm reduction programs. Harm reduction programs are really variable in the services that they deliver, and that's usually content informed but context driven. I don't know any harm reduction program that's adequately funded or adequately staffed or really well supported politically. There may be some. I've heard rumors of them. I'd like to see one at some point, but I've actually not seen any other harm reduction programs than those that exist in local health departments. That's an unusual situation. Most harm reduction programs don't exist in local health departments. So how do we know that we're doing a good job? How do we know that we're doing what we're supposed to be doing? How do we know that we're serving our clients in the most effective way? How do we know we're not wasting our precious resources engaging in activities that are not useful? We needed content experts like Dr. Allen to come in and give us a broader perspective of harm reduction, how it is administered. We could sit together all day and say, yes, it should be low threshold access. It should engage in secondary distribution. It should have this and that. We know those theories. But when we come down to determining how do we best function in our political and economic reality, we needed some concrete guidance. So having this project come look at something as simple as our intake form, we knew from our intake form that there were variances in the reports that we got from intake and what were reported in other research mechanisms among our population. So are those questions that we're asking, and we're getting information that appears not to be consistent with unbiased observers? Do we even need to ask those questions? There are a lot of issues along those lines, and we're always fighting for our political lives here. We really need the support of a review that we can trust, and that other people who look at what we're doing and ask if it's correct, to be able to show a quality improvement effort like this is going to be really beneficial to us. And as we have a leadership position in the state of West Virginia, where there are probably 15 or 18 other harm reduction programs, the impact of what we learn can be disseminated statewide.
Great, thank you. Great reminder how important data is for advocacy. So thank you for sharing those summaries. So I wanted to, I know that in the first project that we heard about with improving equity in food policy, that the result of those of the technical assistance was a restructuring and of the work groups and how you engaged other communities around the issue of equity. So I'm wondering also for the other projects, or if you have other examples within Wisconsin, if you could share some of the kind of next steps or how that work directly impacted how you know, the programmatic changes that occurred or decisions that were made, budgets perhaps. How did the work unfold in the work that you do?
I mean, I'm happy to go. You can call on other people too, but so I should say it was kind of like I don't know what to call it, a perfect storm, if you will, right? Because with the results of the report that we got in, I'd say March or so, right, they kind of coincided with everything that was going on with COVID public health orders, and so in that regard, kind of a reconstitution of the work groups and just a restructure of what we were doing was necessary from a COVID perspective, just because a lot of what we were doing, I'm not going to say it wasn't relevant, but it was less relevant when it came to, you know, the great community need that we are now seeing, and we're seeing in a lot of places across the country and across the world, right, with the emergency food system really being taxed heavily and issues with supply chains and, you know, things like that. So I would say, maybe to answer your question, Amanda, the next steps for us are, right now, the way we're essentially operating, we brought the Madison Food Policy Council together with the Dane County Food Council, but it is not a formal merger. It is a merger, you know, kind of functionally, right? But it's not on paper, legislative, budgetary. And so the conversations we're now starting to have are around a more formal merger and what that would look like in terms of achieving budgetary parity, policymaking ability parity between the two jurisdictional bodies that are, for right now, separate, right? So what does that look like to actually come together? What does that actually then look like from a representation perspective too, right? Because as it stands right now, the Food Policy Council is probably one of the largest BCCs for the city. I mean, it's larger than the Common Council. We have 23 people, and the Common Council is 20 people. And so on the county's end, it's about 9 people, right? So, I mean, that just becomes a bit too unwieldy of a group. How do we start making decisions on, you know, how large should we be? And then how do we make decisions on who should slot up those roles? One of the recommendations that came from Dario's report was we have a lot of specificity currently within our roles and functions, right? So you know, certain folks who can fill certain positions have to have certain qualifications. And I think one of the things that Dario said in his recommendations was that if the interest is in having more true community representation, you have to kind of break down those silos and barriers. And so make it more open to community members. But that, you know, that alone isn't going to solve anything. You also have to find ways to, instead of just inviting people to your table, sit down with people at their table, right? So go to different community-based neighborhood meetings. Don't even show up with an agenda, right? Just show up to kind of show your face, introduce yourself, but don't come in and try to, you know, wedge your way and wedge your issue into whatever their issue is. Just come, participate, listen, build relationships, and then, you know, when the time is right, if the time is right, use those relationships in a way that's then beneficial both for the person you would be trying to recruit, but also to the body you're recruiting them to. And I think I'll kind of wrap it up here to turn it over to other folks, but Dario in his report actually said something that really stuck with me, in that the way that we structure our committees right now, by and large, just committees, period, not even just the Madison Food Policy Council, is that we tend to try to work as efficiently as possible. Efficient in, you know, the sense of the word, in that we have 2 hours to do X, Y, and Z. We got to get it all done. In between now and our next meeting, we're going to do X, Y, and Z, and we have a very laid out plan. And what essentially trying to increase racial equity or racial representation on your group, a lot of what that is quote unquote inefficient work, because it's relationship building. And it's not transactional in that regard, right? Because if you go in, I mean, I guess you could go in with kind of a transactional framework about it, but in the end, what you're trying to do is build up genuine relationships so that you can figure out, is my group the group that people want or need to be involved with? And in that regard, nothing is promised from doing that work. therefore making it somewhat inefficient. And it's, so you have to make that very conscious investment of time and staff resources to say, there's really nothing promised from a transactional perspective here for us to go into communities, listen to people, meet with people, meet people. But we're going to do it because that's important to us moving forward and important to our council in terms of having that representation and you know, that different perspectives in how we do business, and in terms of actually figuring out if what we're doing is impacting the people that we purport to care the most about, or purport to say, you know, these are the people we really want to serve. So I'll leave it there. I think there was a lot of recommendations that, you know, it's going to take a lot of work on our part, but at least it lays a framework and the foundation for us to start exploring.
Anyone else have thoughts on impact, especially if it's policy related?
I can go quickly. So as I'm sure a lot of people can relate to, you know, COVID has delayed a lot of our ability to take action on some of the stuff that came out of this collaboration and the actual, you know, report that was put together. But over this past year, like 2019, 2020, for our health equity zones was the beginning of a new funding cycle for them. And so in the first year of the funding cycle, we asked them to do a comprehensive community assessment and prioritization process, and then to develop an action plan. And so that all kind of completed around the end of June. And so they'll be moving into, from that action plan, how are we gonna, you know, evaluate that? And so I think that this project and the product of it is gonna be really helpful for that. And typically we haven't met in a few months, but I convene a group of all the evaluators from all of the health equity zones to kind of talk about evaluation issues and to, you know, provide some technical assistance and stuff. So I'm really looking forward to getting a chance to talk more in depth about all of this with them. But I would say from like a larger perspective, this project has been really, really impactful for us in being able to talk about evaluation for the initiative and all of the challenges that come along with it. And kind of as Daryl was mentioning, that population level health outcomes or population level, you know, social determinant of health outcomes are not a good evaluation measure because it's just not really a fair thing to compare to. So for example, like one of our HESs might be, one of our HESs has developed, you know, like 30 affordable housing units in their community. But if our measure is housing affordability for the entire city, that's not really a fair measure. And I think that this project and working through all of those issues has really allowed us to have that conversation with our leadership, with the executive leadership across multiple state departments, and even like the governor about what really is an outcome of the HES initiative, and you know, to tell the story of how we're like really empowering communities and having an impact, even if it doesn't show up in population level data sources or measures and stuff like that. So
a lot of faculty and governmental agencies alike struggle with making connections and finding the people that they need to talk to, creating those networks. So I'm wondering if any of you can share how you initially how did you meet your public sector partner, or vice versa? How did you get connected in the first place? Or do you have recommendations for how individuals who, you know, you could benefit from a collaboration with, how they might begin a relationship with you?
So I can take a stab at that. I will say, as an academic, I get tons of emails, and if you are on the other side and you're trying to get in touch with me, if I don't respond in 2 days, send me another email, please. You have my permission. Email me again until I respond. In terms of meeting collaborators, I would just say go to conferences, talk to people, brainstorm, ask people to introduce you to other people. I know with Dr. Kilkenny, we met through someone else in West Virginia. So again, just build your professional network at every opportunity you get.
Anyone else?
Yeah, I mean, I kind of already said it earlier, but you know, it's kind of what Dr. Allen was saying. I mean, it's using your networks wisely. So, you know, I participate in the Food Policy Advisors Network of the U.S. Conference of Mayors. That's how I know Shelley Suttles, Dr. Shelley Suttles, who again was the food policy coordinator for the city of Indianapolis. And I think it came up through an update that she was given to that full network around the work that she had done with CLF. And so got my, you know, kind of got the ball rolling on my end of like, maybe that's something I should explore. So I just set up a call with her and she talked about the project, and she recommended that I do it. And I had already known Ann. So I can't remember if she sent an introduction email for the project itself, but, you know, then, you know, I reached out to Ann, and that's what kind of got this whole thing started. But you know, I wouldn't have even really thought to do it had I not seen a real life case of it working and actually impacting someone who I kind of and know and whose work I trust. So I do think kind of using those familiar connections within your network, asking the right questions, if you will, can open some avenues on action on things you might have already been thinking about.
Great. I just want to also encourage participants to ask me questions. So I will continue asking my questions until I see others. For the faculty on the webinar, can you share a little bit about how this has impacted your work? I know from my experience working with Baltimore City that I've got some of the best research questions, you know, things I didn't even know, you know, the agency needed to learn. I got that from collaborating with the agencies and bringing that back to my research. So I'm wondering how your technical assistance that you've provided, how that has directly impacted what you do.
So for me personally, I'm obviously at Hopkins and definitely not at the health department every day like Dr. Kilkenny, seeing everyone that comes through the door. And every time we write up a paper or a grant proposal, I really look to him to provide that insight of, does this even make sense? Is this what you're seeing on the ground? Even just basic feasibility, you know, what does data collection look like? So this consultation fund, it really provided a lot of insight into the day-to-day operations and really informed a lot of the work that I still do this day.
And if I could kick in from our side of that we take our work very seriously. We actually, because we're one city, one county, and we have a fairly sizable reach into our target population, we do anticipate changing the statistics of our jurisdiction. And we're not interested in doing something that doesn't change the statistics of our jurisdiction. So when we work really hard on doing something like this, and what we say is backed up by publications from Hopkins, like Dr. Allen has done in the American Journal of Public Health, when we have other publications in the MMWR regarding HIV, when we realize that any restriction we put on harm reduction increases our HIV statistics, we need that additional credibility that's brought from these consultants and the work that they're doing to overcome some of the objections that we have to what we do, which is not palatable to everyone. So we find the work extremely rewarding and the help really, really valuable.
Yeah, I was going, would add that with regard to the work that we've done with Katie, in Rhode Island. I often said when we were part of the evaluation of the Maryland Health Enterprise Zone initiative, and when I would talk about those zones, I would say, if you've seen a HES, you've seen a HES, because the 5 health enterprise zones in Maryland they're all different, and they're based upon the needs of the community, and because they're designed by persons within the community trying to address the barriers that they perceive with regard to their access to healthcare, or to improve some health metric that's in their community. They all look different. The same thing was true in Rhode Island. And the ones in Rhode Island don't look like the ones in Maryland. So to try to use even just sort of a cookie cutter template and say, this is the way in which these programs should be designed and evaluated is the wrong approach, because in a real sense, what the state is doing is allowing communities and neighborhoods to address perceived needs that they have, and then the state then has to decide what is it, how are we going to evaluate their progress, and it's in real sense it has to be a negotiation between the Department of Health and the local community as to what it is that they're going to measure to try to impact their outcome. And it's all in this frame of, we know that social determinants of health matter. And we know that if we improve them, that ultimately we're going to get good health outcomes. But in this community, it's transportation. In this community, it's education. In this community, it's food. And so all of them have to be different. And it's just understanding and how to deal with that kind of flexibility, I think, is one of the important takeaway points that I walked away with.
Great. Thank you all. So I want to be respectful of everyone's time. I know we've got 1 minute, and we've heard a lot about how public sector academic partnerships have helped both the faculty with understanding sort of under the hood and what's going on, and how they can be more helpful. We've also heard public sector partners talk about how working with academics can help add credibility to for advocacy, and also accountability for the work that they're doing. If anyone is interested, our participants interested in learning more about how to engage in these public sector consultations, you can email americanhealth@jhu.edu. So thank you very much, panelists, for your contributions and the work that you do. I'm going to turn it over to Shane for some final words.
Thank you so much, Amanda. And again, to everyone who's participated, thank you so much for sharing, and most certainly for participating in this important work. For those of you who are attending this webinar, another great opportunity to share with you is our Bloomberg Fellows Program. You can find more information online at americanhealth.jhu.edu, but we do provide fellowship opportunities for those interested in exploring and gaining an MPH, and those of you who already have your MPH but would like to further your education through the DRPH program. So go to our website, americanhealth.jhu.edu, to learn more about our fully funded fellowship program. Thank you all so much for attending today. We wish you well and good health.